This is a presentation for Charles Sturt University on behalf of Scott Brennan, demonstrating how each point of the AEP scope of practice was met during work placement at MacArthur Exercise Physiology Clinic. The AEP scope of practice consists of the 8 items shown in this slide. Each of these items have been outlined and established by the Exercise Sports Science Association of Australia, also known as ESSA. Each of these items will be addressed during the presentation. For further information about the AEP scope of practice, the link to the ESSA website will be provided. The first scope of practice as an AEP involves screening and risk stratifying to ensure the safety and appropriateness of exercise and physical activity interventions. The purpose of pre-screening is to identify and exclude individuals with health-related contraindications to exercise and exercise testing, identify individuals who should partake in medical screening and exercise testing prior to commencing exercise, identifying individuals with medical conditions who need medically supervised exercise training regimes, as well as identifying individuals with special needs. Pre-screening may also help reduce the risk of sudden death or injury during exercise and exercise testing. During my time on placement, I used the adult pre-screening tool, which was developed by ESSA and Fitness Australia to help assist health practitioners to appropriately screen and risk stratify their clients. The pre-screening tool consists of 3 stages, with only the first stage being compulsory. The first stage of the tool is a simple yes/no question. If the client circles yes to any of the questions, they are required to receive a clearance from their general practitioner prior to exercise or exercise testing. This tool was designed by ESSA and is similar to the American College of Sports Medicine Health Fitness pre-screen questionnaire. The questionnaire is more appropriate to exercise physiologists as it covers a greater range of health conditions and identifies clients who may be at high or moderate risk. The APSS tool was developed by collaborating a number of studies about exercise testing and screening for many different conditions and is the gold standard. The next scope of practice item for an AEP is to assess a person's movement capacity in people of all ages and levels of health, well-being or fitness. Movement capacity is assessed in all the clients I worked with during my work placement. Each client should be assessed for cardiovascular fitness, muscular strength, endurance, and mobility. The purpose of exercise testing is to educate clients about their present health and fitness levels relative to their sex and age groups. It also helps provide meaningful data to the health practitioner to enable them to develop a safe and effective exercise program. It allows for comparison between pre and post interventions. It helps motivate the participants by establishing reasonable and attainable goals, as well as enabling risk stratification. Here is an example of a fitness assessment I conducted during my placement to assess the movement capacity of this particular client. The assessment exercises chosen to assess the client are based upon the current ACSM guidelines. It is recommended that fitness assessments should include a pre-screening risk stratification, take some form of blood pressure or body mass, body composition, cardiovascular fitness testing, muscular strength and endurance tests, as well as a flexibility and mobility test. The Astrian cycle test and 6-minute walk test are simple and effective submaximal tests which can be used to predict cardiovascular fitness and sub-VO2 levels. The test chosen depended on each individual's physical functions and capabilities. The flexibility test chosen here included the soleus, flexion of the lats, extension, thoracic extension, rotation, straight legs raise, and modified thomas, as well as the hip and piriformis, have all shown to be good predictors of musculoskeletal injuries, if not of sufficient mobility. The postural analysis and squat type form provides a clear overview of the client's posture and movement patterns and allows us to develop an individualized exercise program. In this particular example, the client was found to have good mobility and flexibility. However, they were unable to perform a body weight squat. The client also showed poor cardiovascular fitness levels. This particular client was a type 2 diabetic and therefore exercise prescription was looking to address these areas of concern. A primary role of an accredited exercise physiologist is to develop and prescribe safe and effective exercise interventions to a dispersed range of clientele. Exercise programs should be prescribed to the clients developed using the information gained in the previous 2 scope items, as well as based on the client's current health status, goals, contraindications to exercise. During my placement, I developed a number of safe, effective, and individualized exercise interventions. For this particular artifact, I will use the case study for Rosemary. Rosemary is a type 2 diabetic. She has recently been diagnosed with diabetes in the last 12 months. Using the pre-screening tool, Rosemary was identified to be a moderate risk client due to a number of risk factors including a family history of stroke, a relatively sedentary lifestyle, high blood pressure, obesity, and her type 2 diabetes. Additionally, it was identified during exercise testing and from conversing with the client that she has poor balance. Although her 6-minute walk time was normal for her age group, suggesting the program didn't need to necessarily improve cardiovascular fitness, it will still be aimed at maintaining cardiovascular fitness levels. The exercise program will mainly focused on strength and balance training. Taking these factors into consideration, here is an example of a program that was developed for Rosemary. The program consists mainly of the 3 basic components: cardiovascular fitness, strength, and flexibility training. The program was developed using the latest research about exercise and type 2 diabetes. Current research tends to suggest that cardiovascular exercise should be done every day for at least 30 minutes. In addition, strength training should be performed 3 times a week for all major muscle groups to help build muscle and control blood glucose levels and insulin sensitivity. Flexibility training is also important to maintain good mobility and functioning. As identified in the exercise assessment, Rosemary has poor postural control and balance. Therefore, the exercise program included exercises to help address these issues. The next scope of practice involves providing education and advice to clients to help support and enhance their well-being. The efficacy of exercise treatments are to aid through health behavior and lifestyle changes which target the management of the client's chronic condition. Many clients with chronic conditions may be unaware of the most effective methods to manage their condition, especially in regards to the importance of diet and exercise. Throughout my placement, a number of my clients were directed to the Australian Diabetes Council, which is a great website for newly diagnosed type 2 diabetes looking for more information about their condition. Here is an example of some of the advice clients I worked with were directed to. These are information sheets regarding type 2 diabetes and the importance of increasing physical activity and promoting healthy behaviours. These information sheets are available through the New South Wales Diabetes Council websites. Increasing physical activity in people with type 2 diabetes has shown to have positive health benefits and help improve blood glucose levels. Additionally, balancing nutrition, exercise, and insulin has shown to significantly improve insulin sensitivity and decrease the risk of developing further complications from the diabetes. Scope item 2.5 involves the provision of exercise intervention and education for clients who are at risk of developing a chronic condition or musculoskeletal injury. In this particular population, exercise interventions aim to decrease the risk and or slow the progression of developing more major serious chronic conditions. During my placement, I worked with a range of clientele who were at risk of developing chronic conditions. Here are 3 specific examples. One client in particular had high blood pressure and high cholesterol and therefore was at an increased risk of developing cardiovascular disease. Another client had impaired glucose and obesity and was at risk of developing type 2 diabetes. And another client was a female late 60s who had osteopenia and was therefore at an increased risk of developing osteoporosis. For the purpose of this artifact, we will use the client who was at risk of osteopenia. This particular client, named Lorette, is a 67-year-old female with osteopenia. She is at greater risk of developing osteoporosis if she does not improve her bone mineral density. Her current training goals are to increase bone mineral density, improve balance, and postural control. Using the latest research about osteopenia and osteoporosis, the program shown here was developed for Lorette. A number of cross-sectional studies have shown a positive correlation between bone mineral density and exercise. More recent research, however, tends to suggest that high-impact exercises such as stepping, marching, jogging may be more beneficial to improve bone mineral density. In addition, several studies have shown that body weight strength training, balance exercises, and several walking variations such as rapid walking or exaggeration of swinging arms will elicit positive results in regards to increasing bone mineral density, decreasing postural sway, and reducing the risk of bone fractures. The current ACSM position stand recommends that weight-bearing exercises or activities that involve jumping and resistance exercises should be performed for these types of clients. The intensity of these exercises should be performed moderate to high to help enable bone loading forces. Weight-bearing endurance activities should be performed roughly between 3 to 5 times a week, with resistance exercises 2 to 3 times per week. The durations of these sessions should be between 30 and 60 minutes, with the combination of weight-bearing endurance activities, aerobic exercise, and balance activities. Using these guidelines, this program was therefore developed. Scope item 2.6 involves the provision of clinical exercise prescription for those with existing chronic and complex medical conditions and injuries. For people with these type of medical conditions, there are many considerations which should be taken into consideration when prescribing exercise. These include the extent of the disease, the major symptoms, comorbidities, medications, and safety of the client. For the purpose of this artifact, we will use the case study of Ron. Ron is a man in his late 50s who suffers from ischemic heart disease, type 2 diabetes, hypertension, and obesity. Ron has recently had a coronary artery bypass graft in the last 5 years and has a family history of ischemic heart disease and hypertension. The exercise program shown here was developed taking into consideration the current research about exercise and heart disease clients. An exercise session for a patient with ischemic heart disease should consist of an extended warm-up and cool-down phase of roughly between 5 and 10 minutes. This should include flexibility, mobility, and low-intensity aerobic exercise. Low-intensity warm-ups in clients with ischemic heart disease may help prevent ST segment depression, arrhythmias, and left ventricular dysfunction. An extended cool-down may help prevent post-exercise hypertension or dizziness due to the gradual return of blood pressure and heart rate. In addition to cardiovascular training, resistance training is recommended for ischemic heart disease patients. A mild to moderate resistance training program is preferred to help improve muscular fitness, strength, and to help prevent and manage a variety of chronic, complex medical conditions and risk factors. A typical resistance training program should involve up to 10 strength exercises which are performed for one set of 8 to 10 repetitions. This should slowly be progressed to 12 to 15 repetitions and should be performed at 50 to 70% of the one repetition maximum at an RPE scale of around 11 to 14. Isometric type muscle contractions are contraindicated in this type of clientele. Scope item 2.7 is the provision of rehabilitation and advice for patients following the acute state of injury, surgical intervention, or during recovery to restoring functional capacity and well-being. During my placement, I worked with a client who recently injured his back at work when picking up an object off the ground. Matthew is a 31-year-old male who works for the state emergency services as well as mowing lawns. Matthew's sessions at the clinic were covered under work cover. The goal of his exercise regime was to restore him to full functioning capacity so that he could return to his occupation. Matthew's current condition resulted in limited functionability, poor postural control, and tight hamstrings and glutes. The following program was developed using the current guidelines for treating patients with acute low back pain. Cycling and treadmill exercises were alternated to try and improve Matthew's walking tolerance. Each session he would usually do a treadmill at a low speed of progressively increasing. The recumbent bike was mainly utilized due to its ability of back support, allowing the client to exercise at a greater duration. The flexibility exercises were aimed to improve the muscle tightness of the hip flexors, glutes, hamstrings, and calves. The mobility exercises such as the cat-camel, 4-point loading, hip extensions, enable to strengthen the weakened muscles identified in Matthew. Exercise therapy in the treatment of low back pain has shown to be effective for reducing pain intensity, disability, and long-term functioning. Specific trunk stabilization exercises, such as the cat-camel's 4-point loading, hip extensions, and split squats, have shown to result in the greatest improvements in functional capacity and reducing pain-related scores. The last scope item is the level of healthcare provided. At MacArthur Health Clinic, the majority of the clients I worked with were secondary care. That is, that they were referred to the clinic by their general practitioner to treat their chronic condition. These may have been either part of the EPC program through Medicare or by a work cover. A lot of the clients that had originally came under the EPC have continued to stay at the clinic with gym memberships in the continued treatment and management of their condition. Some clients at the clinic, however, may have been primary, as they were walk-ins wishing just to seek private consultation in the development of exercise and treatment. This presentation addressed how each of the scopes of practice items in the AEP were demonstrated by myself while working at MacArthur Exercise Physiology Clinic. Here are a list of the references to support the evidence and findings used throughout this presentation.